being a rehab physician, I know I had a gut feeling, let's put it that way, that people bring with them their history, I mean, their comorbidities, but they're also living condition that has an impact on outcome. So we have students doing semester works with us in order to get their graduation. And this student came up to me and he said that sort of, how come that I'm doing fine where other people that are born in or live in the same area where I went to school with, they're not as successful. So we decided to see what we could look at regarding these softer areas that we're not very often as physicians look into, like where people live, their living conditions, their income, their education, where they're born, etc. So we have a local stroke quality registry in Gothenburg, Sweden, where we have almost 7,000 patients that have been entered data regarding stroke severity, comorbidities when they came to the hospital, physical activity level, etc. And we combined those data with data from the Riksstroke, the Swedish National Quality Register that has a long-term follow-up. But we also went to the National Board of Health and Welfare because they have data on all specialized healthcare that a patient has had at a hospital, whether it's inpatient or outpatient. So we got that data as well for these patients in order to look at other comorbidities and make up, for instance, Charlson Comorbidity Index. Also prescribed drugs that they've taken up to 2 years prior to the stroke and then also afterwards. And then we combined that with data from Statistics Sweden regarding the household income the last 2 years prior to the stroke, also where people are born, level of education, etc. So the National Board of Health and Welfare merged all these data files. They were merged because we have personal identification numbers, so they could merge them, and we were sent pseudonymized data back, so we could not identify anything. So it was ethically completely safe. So we looked at these data and we could see that, yes, the traditional risk factors such as atrial fibrillation, diabetes, yes, they do, of course, have an effect regarding mortality after stroke. But we were specifically interested in the social demographic data such as age, gender, income, where you live, and educational level and where you were born. And we divided our city because our city has around 800,000 catchment areas. It contains both rural areas, archipelago with fishing villages, as well as high rises, and also what the police call blue light areas. 8 of those areas there are socially insecure and they don't really like to go in there that much. So we looked at to see who lived in those more dangerous areas, and we looked at them compared to the rest of the people. And then we looked at these different risk factors, like income. We looked at the different quintiles for income. We looked at the living areas, looked at education level and country of birth, as well as sex and age. And what we could see that higher income and higher education was a positive factor. And we could not see that much different depending on living quarters because there were not enough people living in the poor areas. So we can't say that it's not a factor, but we couldn't really analyze it very much. But we could see that things like being poor is a risk factor of having a poor outcome after having a stroke. And this is in a country where healthcare is free, it's tax financed. We have quite a small width when it comes to income variation, and also so people go into we have 3 hospitals. People just go in, the ambulance drives to the hospital that is closest, or if you need thrombectomy, they drive to one. So that's given to everyone, no matter your income or the money you have in your wallet. So what we could see was that still, in spite of that, income had an influence on outcome. And we think that this has to do with that we know the richer people, the wealthier people, often have a better overall health status. That might sound strange when it's a tax finance system, but going and see the doctor, they consume more healthcare. compared to the poor people. We know that from statistics, and it means that if you go to see the doctor, you usually need to take time off from work, which means that there's a loss of income. And if you have a very low income, those crowns that we use, the Swedish crowns, those money are the ones that you actually need. We also know that poorer people often have not as good eating habits. They have also worse oral health, because it's also more expensive to go to the dentist. There are a higher number of smokers, and there's also less. They follow the recommendations when it comes to prescription and so on, less than the high-income people with high education. And I think that what we need to realize is that we as physicians, we cannot fix the whole society, but we can point out that these are problems that are outside the healthcare system but has an impact on the healthcare system. We also need to realize that when we give people folders or prescribe drugs, it's not only just handing over the paper, it's also making sure that the person who you hand over to actually understand why they're asked to do this, why they should stop smoking, or why they need to take these pills, etc., or whatever, or change their lifestyle behavior. And I think that is a challenge for us to understand that we need to differentiate our message depending on who's on the other side of the table. We're waiting on an ethical approval to get data from 4 years from Rikstroke, and then we also want to merge it in the national cohort, because 7,000 is fine, but we have around 25,000 strokes per year in Sweden, which is not a lot, but it's still quite a number. With 4 years, we'll have more people, and we will be able to explore this further, because I think that even in a tax finance country, Sweden, this is a problem, and we do know that we have around 1/5 of the population is born outside Sweden, Europe, or outside Europe. So there is a diversity in the population, and that requires that we change our way of working with primary prevention.